Good morning, everybody. Thank you for coming to this very early symposium on channeling the myotonia diagnosis. I think you're all very brave to be here so early today. Just shortly, some housekeeping. The symposium will be recorded for a future webinar, of which you will get more information later. So stay tuned. And so the agenda for this morning is, first of all, we will give some introduction on recognizing myotonic disorders. Then Dr. Basset will talk about a large European DM scope registry, which helps classifying myotonic disorders to improve the diagnosis. Then Professor Wissing will give some cases to see why we don't meet the patient sooner, and then we will conclude and you will have the opportunity to ask many questions. These are my disclosures, and so first a small introduction. So myotonic disorders, we have on the one hand side myotonic dystrophy, DM1, DM2. These are rare disorders with a prevalence of DM1, 1 in 8,000, and DM2 is even rarer. The pathogenesis is based on an impaired chloride channel function, of which we will hear much more later. The onset in DM1 is variable. It can be a congenital onset, or childhood or adult onset, whereas DM2 has an early adult onset. On the other hand, there are the non-dystrophic myotonia. They're ultra rare, meaning much rarer than DM1, DM2. The prevalence of the dominant forms is 1 out of 250,000 to 1 in 400,000, and the recessive forms 1 in 25,000. Here it can be a problem of the impaired chloride or sodium channel function. We will split them in chloride channelopathies, that's the Thomson, the dominant, and Becker, the recessive myotonia congenita, and then the sodium channelopathies, of which we have several phenotypes. There is quite some disease burden associated with myotonic disorders. So in myotonic dystrophy, there is clearly a multisystemic impact of the disease with myotonia, cardiac problems, endocrine involvement, and also central nervous system involvement. There are clearly issues with daily living. The patients have challenges with everyday tasks, often incontinence, speech and swallowing difficulties, and cognitive symptoms. There is a reduced activity. In some patients, especially DM2, we will have pain as a symptom. There are behavioral issues and social withdrawal. So in the myotonic dystrophies, there's a clear substantial disease burden with impairment across many aspects of life. In the non-dystrophic myotonia, here myotonia is the main cause of the burden. And this is associated with negative emotions, social anxiety, a lack of independence, issues with daily living, a reduced activity, and the patients perceive the burden increased over time. There is not only for patients but also for caregivers a mental and physical health or an effect on mental and physical health. They worry about disease progression, and there are also some sleep disturbances due to this. So here in NDM, disease burden is constant and lifelong for patients, both patients and the caregivers. There are quite some challenges identified in the management of myotonic disorders. So in myotonic dystrophies, we know there is a progressive muscle wasting and a multisystemic impact. Myotonia is perceived as a low priority versus the other symptoms that occur in this disease. And 70% of the patients and caregivers want more information on therapies. In non-dystrophic myotonia, the disease burden, as I already said, is largely due to myotonia. The myotonia is clearly underestimated. Many patients develop their own coping strategies, and 4 in 10 people with NDM do not receive treatment for stiffness or myotonia, despite an approved anti-myotonic therapy. So NDM and DM can be difficult to diagnose, and there are several reasons for this. There are heterogeneous symptoms, there is a variable disease onset, and these reasons lead to the fact that the average diagnostic delays are very high. As you see here, for DM1 it's up to 7 years, DM2 up to 14 years, and in NDM there is a typical diagnostic delay up to 15 to 17 years in these patients. So possible reasons for delayed diagnosis of myotonic disorders. So there are delays seeking medical help. So the patients don't ask. The people, so the specialists or doctors that see these patients don't refer because the disease is not well known. There's not enough awareness on the disease. Another reason for the delayed diagnosis are the variable symptoms. Also coping, because patients, they think, well, everybody in my family has this problem and they don't really see it as a real problem. So they cope, they manage, they compensate themselves. There is a lack of disease recognition. The disease burden is underestimated often, and also the awareness on the available treatment for myotonia is poor. So there is poor, so the awareness is poor, but so we know that for NDM there is a treatment, a licensed treatment, and the treatment for DM is completely lacking for the moment. So this is the short introduction, and now my colleagues will go more in detail on these topics. And first of all, I want to introduce Dr. Guillaume Basset. He's a senior physician, neuroscientist, and assistant professor at the Neuromuscular Reference Center in Paris. And he has established this DM scope registry in France. And the registry includes over 3,000 patients with DM1 or DM2. So please, Dr. Basset.
Good morning to everyone. We know that we have the most motivated physician to myotonic disorder here, so this is good to start and to have a deeper view on myotonic dystrophy through the registry data. So these are my disclosure. So let's have a few words on genetics regarding myotonic dystrophy, and starting by type 1. So you know that myotonic dystrophy are divided by only 2 gene defects. So this is much shorter as compared to other conditions, like, for example, CMTs that are much more heterogeneous at the genetic level. And in both cases, DM1 and DM2, the mutation is a non-coding mutation. So it's caused by a CTG expansion, a triplet nucleotide expansion in DM1, while it's the only human condition with a tetranucleotide in the case of DM2. This is intronic mutation, this is non-coding. This is 3' UTR mutation, which means that in both cases, the mutation is non-coding. They are leading to a gain in function at the RNA level by sequestrating some important splicing factor, which is the cause of dysregulation of a number of genes. Among these gene and protein, the chloride channel is misspliced. So in a way, we could see that DM1 and DM2 are both a kind of secondary myotonic disorders. There are secondary chloride channel myotonic disorder. But of course, and this is the explanation for the name, this is dystrophic and they affect many other organs, and which is referred in the name of dystrophic myotonia. So there are multisystemic disorders, both. So the intriguing thing is that in this condition, and in particular in DM1, the clinical manifestations are very heterogeneous and leading to a wide spectrum of clinical abnormalities, and the onset can be different in both the case, more than 5 years for DM1, 14 years for DM2. And we know that there are major unmet needs to increase awareness and to recognize both DM1 and DM2. Today, there is no causative treatment and cure, but there are many different ways to manage the patient, and there are care guidelines that can help you as physician to reduce, in particular, the morbidity, but also the mortality in the case of DM1 due to the affected cardiac and respiratory organs. So the rationale for the DM scope registry is based on this highly variable clinical manifestation. So the main question was, what is really DM1 or DM2? So since this condition can span from birth to late adulthood, so how can we really understand the clinical manifestation to improve clinical care and research in those two rare diseases? So as many genetic conditions, we know that our knowledge is limited by poor standardization. The data comparability between countries, for example, is challenging, and that systems are not that much interoperable. This is why we are contributing to the EuroNMD registry. I will show you in a few moments. There are questions regarding the quality of data and the completeness of data. So in the DM scope registry, this was launched more than 10 years ago, now 15 years ago. And the major aim was to increase our global knowledge on the epidemiological level for both DM1 and DM2, and to contribute to harmonization to facilitate our medical management of DM patients. Finally, this registry is research-oriented to increase the enrollment of patients, the identification of pre-screening and eligible patients to various clinical trials. So let's have a look at how many patients and how many centers there are. This is the distribution of centers in France, and you have on the left panel the pediatric centers, while on the right panel all these adult neuromuscular centers. And we are happy to be nicely distributed in our reference center among the theory, which is called Filnimus in our country. But let's have a look at abroad, and more recently we extended to different countries, which are, for example, on the left side, to North America, and through a nice collaboration with our Canadian colleagues, there's now an IDM scope consortium, which is between France and Canada. And even more recently, 2 years ago, you probably heard, as European, for the European of you, that DM scope is one of the 4 pilot neuromuscular registries to contribute to the next EuroNMD registry hub. So the future will be to gather all the data from different neuromuscular conditions into one large interoperable registry at the European level. We've seen the distribution of centers, but let's have a look now at the distribution of patients. They're represented here by dots, and there is some representation of the centers and the activity of centers. And we are in the start, so this is not a prevalent study, but by having the ratio as compared to inhabitants in all these regions, we can see that some of them, and for example, the southwest of France, near the Basque Country, which is known as a high prevalence for DM1 disease, is represented here. The number of inclusion, which is here, the green line is increasing, probably reaching a kind of plateau now. This is not the aim of the registry to collect the whole population. We know that from recent prevalence study in the US that the genetic prevalence of the condition is even higher than expected. So we know now that DM1 is ranked number 1 neuromuscular disease among Duchenne, SMA, and various other, and it's even probably more frequent than we thought. Nicely, we have this normalized curve regarding the age range, and you can immediately see that most of the patients are in the adult range. So the pediatric one are kind of minority among the DM1 patients. This is also the distribution by age and sex, which is nicely balanced. There is the condition affects equally male and female. However, and we will see that for those interested on Saturday, the clinical manifestations are not the same in male as compared to female. So now there is the question of how to stratify and how to classify this disease. From history, there were many attempts to propose classification. And just to say that we are in Europe and some of the patients are still known as Steiner disease, which is the adult form, which is still not represented here. But just to have in mind and be aware that this is just a part of the clinical spectrum which spans from birth to late adulthood. So there were, from the 60s, a better recognition of childhood onset. And just to let you know that these childhood onset were non-recognized through myopathic phenotype and not with myotonia in particular. So it's mainly a cognitive and brain manifestation. So here, all these patients, they had clinical onset before 18 years of age, and it can be at birth with neonatal hypotonia and very severe manifestation, which is not compatible with survival for some of those patients, infantile during the first decades. And we have identified another phenotype, which is during the teenage, which we called the juvenile. This is something different as compared to the adult. So what was described by Hans Gustav Steiner was in fact this form, which is called now the adult form. Of course, this is the most represented subgroup. The onset is between 20 to 40. Later on, thanks to the genetics, has been identified a late onset group with other more subtle manifestation, mainly non-muscular manifestations. So cataracts, endocrine, GI, cardiac, much more than a myopathic phenotype. So we could see the spectrum as being more neurodevelopmental and brain disease as compared to a more myotonic disorders and myopathic phenotype, and here more diverse clinical manifestation, most of them being non-neuromuscular. This is what we can see here. So the pediatric onset is mainly represented by the CNS dysfunction with neurodevelopmental abnormalities, which leads to some learning defects and behavioral change. As part to what we published is orthopedic sign and GI manifestation. So you do not see here many muscle symptoms or neuromuscular symptoms. This is not the case for the adult onset phenotype, in which I do not like the term classical because I do not know what is classical for myotonic syndrome, but it is much more neuromuscular phenotypic manifestation. And then the late adult could be here with something different on the multisystemic involvement, like cataracts, cardiac abnormalities, GI, endocrine, diabetes, thyroid, and so on. So let's have a look at the number here. So you see by percentage the representation and the distribution of all these phenotypes. And of course, you see that nearly, not half, but nearly 40% of all these DM1 patients are in the adult group. Of course, and by chance, this most severe condition, the congenital one, is very rare. We want by the genetic counseling that it is even rarer. And now is more and more recognized the late onset that was underestimated over the past year. So thanks to the genetic. And the distribution is quite balanced, except for, this is the female. We know that there is slightly more male in the congenital one. I present you the CTG repeats, and we and others have shown that there is a correlation between the CTG number and all these forms that are statistically different. What about the inheritance and the transmission? It is known that these congenital, they were said to be maternal inheritance. In fact, we showed that from paternal transmission, it is represented even in the childhood form. So be careful when you have some male with CTG expansion. This can lead to the next generation to a very severe childhood form. So this is not to be addressed in depth, but we see here the complexity and the variability of all these phenotypic manifestations in DM1. So they can be classified as being statistically decreasing among all these forms, or increasing or not changing. So let's see how they are distributed by ages. Here the age of onset of all manifestations, and the main one, are represented. This is from congenital, infantile to adult and late adult. And you can see that the late adults are after 40, but quite vertical, while the congenital and infantile are more widely distributed, except one, which is the myotonia, which is not present during the first years of life. The muscle weakness can be separated, and also, interestingly, you can see that most of the patients are myotonic, and some of them do have severe myotonia, while a minority of them have no clinical obvious myotonia that can be detected. And in pediatric patients, these are the numbers here, with most other manifestation like orthopedic one. I will not go into too much detail. So to summarize, the pediatric onset patients, they do have reduced physical activities and struggling with some daily life activities, have impact social communication and skill, as well as psychological impact of the disease. Let's have a look at the myotonia here. So you can see we have set the frequency of the myotonia among all these groups. So doesn't mean that these are the number of affected patients, but how myotonia is distributed between severe and non-severe. And we can see that the earlier is the onset of the disease, the most severe is the myotonia, which doesn't mean that it will be early. But when myotonia is there, it's most of the case in this adult and childhood form, rather severe, which is here. So of every 5 patients with DM1, 4 of them have myotonia, and 1 of whom will have severe myotonia. So this is truly a myotonic condition that can make patient interested by therapy to treat these symptoms. So there are, and it has been introduced, clinical diagnostic challenge to have a more early recognition of DM1 and DM2. One paradox is that this is the most prevalent neuromuscular disease. So why not having a more early recognition of them, since the prevalence is very high and even higher than expected across all ages? Of course, is that because the manifestations are very large, very heterogeneous. So even the intrafamilial heterogeneity make the patients that they do not recognize that their child can be affected by DM1. In particular, because the DM1, the pediatric form, mainly leads to cognitive and neuropsychologic manifestation. But interestingly, we see that myotonia as a symptom is highly represented and can be severe. It is differing across the age and the subgroups, but this is a main manifestation in this large phenotypic spectrum. Just I will finish here with this conclusion to highlight the needs to improve our understanding of both, of course, the myotonic condition, the dystrophic myotonia and the non-dystrophic myotonia at the level of diagnosis, but also pathophysiology, and of course to have a clear knowledge on the number of patients that are affected and to measure and quantify the burden of the disease.
Thank you very much, Dr. Bastet, for this very nice overview of these diseases. And now it's my pleasure to introduce Professor John Vissing as our next speaker. He's the director of the Copenhagen Neuromuscular Center in Denmark. Professor Vissing's main research interests are the treatment and pathophysiology of metabolic myopathies, myasthenia gravis, and channelopathies. Please, Professor Vissing.
Thank you, Crystal, and thank you for being early birds. You're very brave. So these are my disclosures. I will be talking about why we don't see these patients earlier on. Again, here we see the different myotonic disorders due to channelopathies. Myotonic dystrophy, as we heard, is the myotonia is not so severe, whereas in the non-dystrophic myotonias here, due to either chloride channelopathies or mutations in the sodium channel in the muscle, are quite severe and bothersome for the patients. We will hear a case about a Becker myotonia, the recessive form. Really, the myotonia is worse in the legs of these patients, and it is slightly different in the sodium channel patients that typically present with these four phenotypes: paramyotonia congenita, where it's the arms mostly, and then we have these two forms. It used to be called potassium aggravated myotonia, and since there were milder forms, it was also then split up into myotonia fluctuans, which is milder, and then myotonia permanens, which is really the most severe myotonia condition that we see. Luckily, it is quite rare and generalized. And then we have patients with hyperkalemic periodic paralysis. These patients do not all have myotonia. I don't know exactly what the frequency is, but I think in our cohort of patients, it's maybe 10-20% of the patients that have significant myotonia. So this is quite a bothersome condition. So patients, and this is from 3 different works looking at the burdensome of having these conditions, either chloride or sodium channelopathy. If you look at stiffness, this is very prevalent in these patients, as well as pain in the affected muscle. So pain is a big issue in these patients. And if we play this video, you can see that this is a patient also with Becker myotonia. She's off treatment here, and you can see this is really slowing the patient dramatically. It's really, and you can see here at the end, it was a little bit easier for her because she was sort of warming up. So the movements are really slow in these patients initially when they use their muscles. Yet, a lot of these patients are still not treated, and nearly half of patients with chloride channelopathies are not treated. And one thing is obviously that many of them go undiagnosed. But even when they are diagnosed, some patients are reluctant to seek help, even though they have quite bothersome symptoms. I've had many families where it is only unearthed that they have this condition because some woman in the family gets pregnant, and then the myotonia, it worsens a little bit, and then they're worried about that child, and then you diagnose the whole family, and they actually have quite bothersome myotonia, but never been to a doctor. But of course, there's also very poor awareness about these conditions especially for GPs, and that's what patients usually seek help first. These symptoms are quite ordinary, pain and stiffness in the muscles, and if you don't examine them, you don't really see the striking myotonia that they have, and you can think it's just one of these other people with muscle pain and muscle complaints. Right, so this is the case, and this is really quite typical. So this is a gentleman that started off having symptoms of myotonia at the age of 14. It was so bothersome that he asked his mom to go to the doctor, went to the GP, and the GP thought this was probably growing pains. And then he went home again. He had to stop athletics in the school. He was not participating in these classes, so it had quite a big impact on him. And at age 16, he went several times to his GP again, and there were several blood samples taken, and then a random borderline B12 vitamin deficiency was discovered, and he was then treated, and he got a little bit better, but this was during the summer where, these patients get well anyway, and I am sure that there was no real deficiency in this patient, but it's quite common to hear this also for other diseases. That's another thing. He then graduated at age 17, and he was really perplexed by his condition, and he wanted to be a carpenter, and didn't go into this field because he had his muscle symptoms, until the authorities told him, now is the time, after 3 years of going around, get an education. And then he trained to become a carpenter, and he worked as such, and he was actually quite good carpenter, he said, but having massive problems, as you can imagine. It's not the best job to have when you have this condition and it's untreated. So after 7 years working like this, he developed a stressful condition he stopped working and he went on sick leave for a long time, not having any jobs at all. Then his father saw a neurologist and told about this condition, and the neurologist said, I think I may know what is wrong with your son. And then they asked the GP to refer him, and he was very reluctant to do this because, you know, he didn't think it was anything. So it did actually take some time for him to get to this general neurologist who picked up the diagnosis. And when he did go there, he just wanted a diagnosis. Really, he was completely unaware that there might even be a treatment for this condition. So he was then seen at age 33. So this is 19 years after, you know, his initial symptoms, and basically he hadn't changed. I mean, his myotonia had been very constant since. And as you can see on the gentleman here, he has muscle hypertrophy. He doesn't do any exercise at all, and this is very common in these patients. Here you see it again. His quadriceps is big biceps muscles, and and if we look at his muscle MRI, you can see the hypertrophy there. Hardly any fat. It's in the thigh. It's all muscle, and I'm always a little envious of these guys when they come in. You know, they don't do anything and they look like they work out every day. But of course they are in trouble. For some women, actually, you know, this is a problem because they look like bodybuilders and they want to look more feminine. And I have had several patients that take Botox, you know, to reduce the size of their calves or whatever, or even their masseter muscles. It's not uncommon. Something that is also done a lot in Korea for cosmetic purposes. But some of these patients actually do this because it is bothersome. Right. This is again just showing really that this is quite striking muscle hypertrophy. And recently we have done an MRI study in a series of these patients measuring their cross-sectional area of the muscle, and they do have muscle hypertrophy, most of them, but it's not all of them that have this, which is probably due to the constant training they do because they have myotonia all the time. So they, you know, go and do small muscle contractions. We don't really know why that is. So when he got to the neuromuscular clinic, we started with lamotrigine, and that works in a lot of patients. It didn't work so well for him, and so he was switched to mexilitine, and he felt that worked better, and he's on this treatment now. Genetic testing showed that he had this quite common R894X mutation. It's a quite common mutation. It's also an interesting mutation because it can confer the disease in a dominant manner and in a recessive manner. So his mother had similar symptoms, although milder, and of course she's a carrier. Obligatory carrier. The father who allegedly did not have any symptoms, he's also a carrier. So this we have seen in several families. But when you have it in a recessive form, it's more the myotonia is worse. And actually, he felt so worried about his condition that and thought this was a hereditary condition even before, you know, getting the diagnosis, that he didn't want to have kids. It's quite worrisome, I must say. So this is just to show you on the right. This is the video from before, And that video over there, look how fast she is. And you would think that's treatment. Actually, she's not on treatment there either. But she has just done this exercise 5 times before. So she's a lot quicker, just with the warm-up effect. Of course, treatment would do something similar. So how do we diagnose these patients? And as urologists, it's easy peasy, really. I mean, they are so easy to diagnose. So the trouble lies elsewhere. Because, I mean, the myotonia is striking. And in most cases, I would say you don't need to do an EMG because it's in your face, the myotonia that they have. Of course, if you're in any doubt or EMG is very easily accessible, fine, do it. But I think in most cases, it's not necessary. And then today we move very quickly to molecular testing, and of course we should take the family history to find affected family members as well. So so the patient we saw had the recessive form, the Becker myotonia, and it's somewhat more prevalent in Europe. In Denmark, the Thomsen form. Thomsen was a Danish physician that was named after him. So maybe, this mutation is, his mutation is quite prevalent he had the disease himself, and the mutation they carry in that family is quite prevalent in Denmark. So Thomsen myotonia is more prevalent in Denmark, but worldwide it's the other way around. So as we already alluded to, they differ a little bit in that the recessive forms have more affection of the legs, whereas the Thomsen patients have a little bit more in face and arms. This is not an absolute thing, and it could be, vice versa. It's actually and also the issue of paradoxal myotonia that we see in the sodium channelopathies. You can actually also see this in 20% of the chloride channelopathies. So the way we group it is just a general rule. Remember that. Don't follow it strictly. Have an open mind, because it's not all textbook when you're out there. Otherwise, they are quite similar, and I mean it's the same gene anyway. Pain is probably a little more prevalent in Becker myotonia patients. Also, they can have episodic weakness in conjunction usually with these myotonic attacks, which is not the case in Thomsen myotonia. So why don't we meet the patients? I mean, clearly there's a patient delay in many cases. I've seen that several times. They just think this is something that runs in the family. They actually make the diagnosis, at birth, because they hammer on their child, and they tell me, they can actually diagnose very early on in many cases. And that's, of course, difficult to deal with. We can't educate the whole population for such a rare disease, but we can try and educate our general physicians, because this is really so much in your face. If you examine the patients, you will actually see this, and the GP should be able to do this as well. Clearly, the B12 business and other patients run into a lot of blood samples. One is slightly abnormal. You try and treat that, and then just by accident the patient gets a little better. We hear that all the time with a lot of conditions, and these guys run into this very often too. The mother didn't want to be treated, didn't want to see a physician, and probably she had myotonia, from what we hear, but much milder than the patient. Right. So it's a little disappointing that there is such a huge delay in diagnosis for these patients. It's usually more than 10 years before they are diagnosed. Obviously, you know, if you run into a family and then you can diagnose all these patients, it's quicker, but they have already had symptoms for many years. So even for them, it's a delayed diagnosis, you can say. So it's a pity because these patients can be treated quite well with medication these days. So we should really try to educate all our colleagues about these conditions, although this is really rare because it's simple to pick it up on a very small examination to find the myotonia. With that, I think I will stop.
Thank you very much, Professor Vissing, for this very nice case presentation. You already summarized perfectly, so I think we all agree that awareness, increasing the awareness on the disease is really very crucial, and I hope that this symposium can contribute a little bit to that. First of all, perhaps I will come back to this later, but are there any questions from the audience? Please.
How could one explain the distribution of myotonia, which is different, for instance, in the Becker form than in other forms? Predominant in lower legs versus legs or not. Can you explain that? For instance, in my experience, more in the hand rather than in the lower legs. And I've had patients exactly that, like the one you showed, with difficulties in walking when standing from a chair, exactly the same thing. So, how could one explain the distribution?
You can't. No, you know, you can open that question and say, you know, for muscle diseases, why are some muscles weak in limb-girdle muscular dystrophy? Why is the proximal muscles, and why is it distal muscles in other conditions? I think the answer to this is probably that the 240 muscles that we have, if we lay them out on the table, they all look like beef. But, you know, they are individual organs, and if you do a gene expression study on these 240 muscles, it's completely different organs. They're expressing different genes, and I think that's probably why we see these differences, different organs. We shouldn't regard them as one, although they do the same thing, move us. So, I mean, the pain the patients get is related to the myotonia they have. So that is also relieved when you treat the myotonia in nearly all cases.
Another question is, here the myotonia is correlated with muscle hypertrophy, while in myotonic dystrophy you have an atrophy. And in the first case, it's painful, it's like annoying the patient, while in myotonic dystrophy, frequently they don't even care about the myotonia unless it's really annoying for the work or what do you think about that? How do you explain this?
Yeah, sure.
Yes, probably one answer is that in myotonic dystrophy, this is the combination of two different aspects and manifestations. So on one side could be seen the myotonia as a symptom, which is at onset and in younger patients, much more similar to the non-dystrophic myotonia and rather similar to the chloride channel myotonia. A little bit more like the Thompson one, so less severe and less associated with muscle hypertrophy, since myotonia can be seen at the physiological level, at the electrophysiological level, as muscle membrane hyperexcitability, so over contraction which probably leads this muscle hypertrophy, this spontaneous hypertrophy without practicing. And then comes another phenomenon, which is the dystrophic as pattern. Something similar to other muscle dystrophy, in fact, that are non-myotonic dystrophy. So we can have this balance between different parts of the disease. So myotonic dystrophy is very heterogeneous. And also something underestimated is pain. So it's frequently said that DM patients do not have pain. In fact, it has been recognized for DM2. But now, by survey and when you properly checked the pain symptom in DM1 patient, it's highly prevalent. It's up to 60%. So you can have this aspect, myotonia as hyperexcitability, muscle wasting, and atrophy as a dystrophic pattern, and pain.
So, and with that, I think we can conclude this session. Yes. So I thank all of you very much for being here today. I thank the speakers and I thank Lupin for organizing the symposium, and I wish you a very nice day at the Congress further. Bye-bye.